Harnett from the AEP program here at Princess Margaret. I'd like to welcome you to the next in our series of webinars. This particular course is the Liver Metastases SBRT session, ready for prime time. I'd like to introduce Laura Dawson, who is the course director, and will introduce our guest speaker.
Thank you. It is a great pleasure today to introduce Dan Chan. He is an expert in SBRT, perhaps known a little bit more for his pioneering work in pancreatic SBRT, but I've had the chance to collaborate with him on liver metastases SBRT, and it's been a pleasure. He's also an editor at Red Journal, so he knows a lot about what we're all doing and researching. He spent time at University of Michigan, Wayne State University, University of Florida. He's now at Stanford, where he's an associate professor and very prolific. And one thing that he has done that's similar to me, he's embarking on phase 3 trials, but in pancreatic SBRT, looking for very clinically important endpoints. So very exciting, very challenging. Perhaps what I found most interesting that I learned about him before this talk is that he is Canadian and he loves ice hockey and he roots for the Detroit Red Wings. So. Anyway, being a Red Wing fan, you actually will fit in just perfectly in this audience because we don't have many Toronto Maple Leaf fans these days. So with no further ado, welcome, Daniel. It's a pleasure to have you. We look forward to your talk on liver metastases.
Thank you, Laura. So again, it's a pleasure to be here. I love Toronto. I used to come here a lot as a kid, and it was just kind of a short few-hour drive from Detroit where I grew up. So it's always fun to come back to visit. Probably summertime, maybe the next time I will let it to probably spend the time here. So the title here is Ready for Prime Time, which I think is always an interesting question. Before I get to that, let's make sure I do my disclosures, which is already in the in your handout. So the outline here is kind of centered around that question about really how can you really answer the question of if a modality is really ready for prime time? Because I think there's a lot of questions that still need to be answered. But I think from the baseline efficacy point of view, I think we have a lot of data now to really show the impact and efficacy of SBRT. So the way I've outlined the talk is really what is the current use of SBRT? How is it being used? Which patients may benefit the most from local therapy? Because I think that question really isn't unique to SBRT. It's unique to really any type of liver-directed therapy. And we can learn a lot of lessons, I think, with SBRT from what we've learned from other modalities. What other modalities are there? I think for those of us who are trying to start a liver SBRT program or want to become more active in this, we need to, of course, understand the landscape, understand what are the other players or stakeholders in this field. Then I'll review the results of SBRT, dose, histology, those types of things. But then I think a bigger question that we'll have to answer to really get SBRT to become a major primetime player is to understand and compare SBRT to other modalities. And then finally, I just ended with the future directions where I think the field is going. So this is just my overview timeline, which was sort of brought up also with one of Laura's talks yesterday. But the field of SBRT was pretty much born in the early 90s when the Swedes published really the first clinical series using extracranial stereotactic radiation. Then in 1998, they published the first series on lung and liver SBRT. Around that time also, I think, Stanford, they started experimenting with SBRT for pancreas cancer. And then in 2004, the first phase 1 trial was published, which pretty much gave birth to the field of pancreatic SBRT. But a lot's changed since that time. And I thought I'd introduce the topic really with this study that I found that came out hot off the presses. It's a nice survey of more than 1,000 international radiation oncologists looking at how is SBRT being used currently. You can see that in the last decade or so, you can see an explosive growth in the use of SBRT for extracranial oligometastases. And so this is interesting. They broke down what were the different fractionation schedules used in different parts of the world. You can see Western Europe, they seem to have a nice spread across 1, 3, or 8 fractions. In the US, as you probably heard from billing reasons, most of these are concentrated as 5 fractions or less. Really, it's not considered SBRT in the US unless it's 5 fractions or less. It seems like 10 grade times 5 is the most common regimen that's used. In Japan, 12 grade times 4. And in Canada, it's a nice spread here too, all 4 or 5 fractions, but varying from as low as 4 gray per fraction up to 12 gray per fraction. And this may be interesting, of course, for those of us who've started SBRT, the reasons why they gave, most people believe that the reason to do it is because it has a demonstrable benefit in local control. And of course, for patients who aren't surgical candidates, you of course want to find a modality that can optimize local control. Also, with the improvement of IGRT, people believe that you can spare normal structures and do it safely. And then for a small number of responders, they also want to be able to do this to perform clinical research. For those of you, or those of us who want to start an SBRT program or want to adopt, what are the main reasons? And I think most of us, again, believe that it's because you do get improved clinical outcomes, primarily better local control, which we hope can benefit survival. And of course, clinical research is important, but I think not to discount these two factors, which really have to do more with competition. How do you stay ahead of the curve? How do you stay competitive in this market? Because you want to be able to offer what you think is the optimal therapy when you're trying to, stay ahead of the curve. So who do best on SBRT? I think the really question is, well, who does best with any type of local therapy? And so I have relied a lot in looking at the surgical literature. This is for colorectal liver metastases. What is the data for liver resection? I think that looking at these very large series, which we can't quite do yet with SBRT, you can see some of these have up to 1,000 or even 1,600 patients. And a lot of the prognostic factors that they found for resection of colorectal liver metastases seem to be kind of common throughout. You can see disease-free interval. A shorter disease-free interval usually predicts for worse survival. CEA is an important marker that seems to come across in many of these studies. Tumor size, grade, and I think that looking at these series can definitely help us when it comes for time for us to decide whether a patient should be getting local therapy or not. This is another study looking at lung resection for colorectal mets, and they found that similar to the previous study or previous table, pre-thoracotomy CEA, disease-free interval, and number of metastatic nodules all were significant. And you can see that by if you look at the number of risk factors by binning them into different risk groups by the number of risk factors they have, you can see that there's a nice distribution, a nice difference in terms of predicting outcomes. This may help us when it comes time for us to decide if a patient that we see really will benefit from local therapy. There's a study here that came out, it's in press actually. It's looking at a pretty large number, about 320 patients with SBRT for oligometastases. You can see that the majority of them were colorectal, and then about a third of them were non-colorectal. They're across several different organ sites, but liver and lung were the primary sites. And they looked at various other factors, and the factors that were the most significant, or that were significant, were performance status, number of metastases, size of metastases, the timing, whether it was synchronous or metachronous, as well as pre-SBRT chemotherapy. And again, you see, based on the number of risk factors, you can get a difference, a pretty dramatic difference in some cases, with survival. And so I think doing more of these studies, particularly with SBRT, will help us to have a better understanding of selecting the right patients. And at some point, my pie in the sky wish is that we have some sort of a very sophisticated nomogram that can pretty much tell us with these factors, which way should this patient go? Should they go to systemic therapy? Should they go to surgery? Should they go to SBRT? And I think really studies along these lines are really needed more. And then finally, I ended with this study here, which I think kind of points us to the direction of, well, the site of metastases probably plays a major role with the difference in survival. This is from the Rochester group. They basically show that it appears that if you have bone-only metastases, you have a much better survival compared to thoracic lymph nodes, lung, and liver actually doesn't do quite well in this group. And so this may be something also that we should probably be paying more attention to. So what about other ablative therapies? I'm not sure if there's any interventional radiologists in the audience, at least on the webinar, but I thought it would be important at least just to give a quick kind of broad overview of what other therapies, at least in my practice too, at my tumor board, I of course have to be able to negotiate and navigate how SBRT fits into the treatment of liver metastases. RFA is probably the most common one, the one that's most well known. This involves basically inserting a probe directly into the tumor and applying energy that causes friction of the ions, which builds up heat. The goal is to get the temperature above 50 degrees to get cell death, but you want to keep it below 105 degrees to prevent boiling, vaporization, and decreased transmission of energy. And in a systemic review, RFA has local recurrence rates ranging between 5 to 40%, which is not out of line with what we see with SBRT metastases. It doesn't seem to do as well for tumors that are 3 centimeters or more. That seems to be a common theme seen in most of these series. Most of the relapses occur within 6 months. But they do say that resection, while resection is superior, RFA does prolong the time without toxicity and survival as an adjunct to hepatectomy patients and or chemotherapy in well-selected patients. So size matters. RFA can improve survival in well-selected patients. And so who are the better candidates for RFA? Patients that are probably best suited are patients who have tumors that are at least 3 centimeters or more away from large blood vessels, because you have that heat sink effect. You want to avoid critical hilar structures and tumors that may be near the dome of the diaphragm or by the bowel. They may be more difficult to do, and you also don't want to damage the bowel. And of course, liver function is also important, similar to SBRT. There's no proven benefit for patients with child C cirrhosis. Microwave ablation is another modality that I've actually been seeing more at Stanford. This involves basically using microwaves to cause oscillations of the water molecules, which can then increase the temperature. And you can get this oval-shaped ablation zone, which is much larger than with RFA. So because of that, you can get larger ablation zones, you can get faster ablation time, and you can actually overcome the heat sink effect, which has some advantages. But the disadvantages are that you get a much larger elliptical type geometry, possibly a risk of the skin burn, and there isn't really yet high-level clinical data comparing microwave ablation to RFA or surgery. This is something I've heard talked about. I do think that perhaps this could become maybe a larger player. This is irreversible electroporation, which basically uses short direct current pulses to cause little micropores in the cell membrane, which then causes cell death. The reason why this potentially has a benefit, has a role, the trade name I've heard is called nanoknife. So if anyone ever hears that, nanoknife is electroporation. The reason why this could be helpful is because it doesn't have the heat sink effect, and you can actually use this to kill tumors that are actually near blood vessels and ducts, and it doesn't have that same damaging effect that RFA may have. So this potentially could fill that void, which I think for me traditionally has been the type of patient that may be referred to me, for instance, for SBRT. The disadvantages, of course, are that it requires patient paralysis. It has very small ablation zones per needle. And there's very limited published data at this point, and it's also very expensive therapy. But I think it is coming up the horizon, so I just wanted to mention that. And then finally, the one I mentioned yesterday is radioembolization. As you know, the liver being sensitive, radioembolization offers a way by using physiologic partitioning to be able to get very high doses concentrated by injecting intraarterially to the tumor. And Y90, yttrium-90, is a pure beta emitter. That's the isotope that is used in this treatment. Has a penetration of 2.5 millimeters, so very superficial, half-life of 64 hours. The two products that are out there, Surspheres has been FDA approved for metastatic colorectal cancer, and TheraSpheres is the product that's used, that's FDA approved for HCC with portal vein thrombus. They both have similar size spheres. One's made out of resin, one is made out of glass. In our practice at Stanford, the patient selection for radioembolization are patients with liver-predominant malignancy. They must have preserved liver function, as you can imagine, performance status being good, and they must have a low level of arterial venous shunting to the lungs, because these patients are also at risk for pneumonitis if they have too much of the radioembolic material shunt to the lungs. And the other, similarly too with radiation, if any of this actually gets deposited into the bowel, you're going to wind up with an ulcer. So they're very careful to look at how much gets shunted to the lungs and really to avoid any kind of shunting to the bowel. There is data, older data, showing that radioembolization can improve survival over chemotherapy, but this was done prior to really the advent or before irinotecan oxaliplatin became the standard of care. So these are probably outdated data, but there is growing data, just so you're all aware, of radioembolization to be used in patients who have chemorefractory colorectal metastases. So switching gears now, let's focus on SBRT. What are the results? Again, a table just showing a select few papers that are out there. I enjoyed Laura's slide yesterday, basically showing that it's really hard to keep up with all the series that are out there these days. But just to know, I mean, this kind of gives you an idea of the kind of outcomes that we're seeing, primarily local controls in this column, and these are really listed in order of kind of from oldest to more recent. And you can see the local controls, especially toward the bottom, seem to be getting much better, closer to 100%, which hopefully means that we're, through the learning curve and through experience, we are getting better outcomes. And you can see that the fractionation schemes really aren't that uniform, but 3 fraction seems to be most common. The one study that I highlight is basically the last one, because to date, this is the study that uses really the highest dose that I'm aware of. It's an Italian trial using a mix of histologies. And you can see the prescription dose is up to 75 gray in 3 fractions, which is 25 gray times 3. That's actually higher than I've ever used. But with that, they found some very interesting outcomes. They found that there was basically very few in-field or near-field progression. Most of the progressions happen to be extrahepatic or extra-field. And encouragingly, they showed near 2-year local controls above 90%. And this is kind of similar to the Colorado series using 20 gray times 3. So dose seems to correlate with improved local control. Survival, of course, continues to be dependent, I think, on extra-field or extrahepatic progression. But the challenge I find with trying to interpret the data is that, for the most part, most of those series that I showed still it's a mixed bag, it's a smorgasbord of many different histologies. And the question that I always really kind of ask myself is, well, how does histology play a role in this? Because it appears that different histologies have different levels of radiosensitivity. And so what I've been trying to focus on, or whenever I try to read the literature, try to do my studies, I try to look at specific histologies. And I really think the only way to do that is to be able to really do kind of larger multi-institutional registry type studies in order to really get the numbers up. Because I think it's hard for any one institution to build a very large volume of one single histology. So we attempted to do that recently with a pool analysis from several institutions here. And we looked at kind of the 3 most common histologies that showed up in the series, and they were colorectal mets, HCC, and biliary tract cancers. And this really was cholangiomas, gallbladders, and anything of that sort. And you can see that the doses seem to be highest for colorectal liver metastases. 3 fractions seem to be the most common, but you can see the BED, by standard linear quadratic at least, was the highest for colorectal, lowest for HCC. And this probably had more to do with perhaps underlying liver function and the concern there. But I think the important takeaway point is that there is a difference in local control based on histology. As Laura mentioned, HCC does appear to be a pretty radiosensitive histology, and so outcomes there seem to be quite good. Colorectal mets seem to be doing the worst. However, if you look at survival, it's actually interesting because it's almost reversed. The patients that have the best survival are colorectal cancer patients. That probably has a lot to do with patient selection as well as with systemic therapy, whereas HCC and bile tract cancers seem to do worse. So looking at this, we've got to find a way to improve local control for colorectal metastases, and we need to find a way to improve systemic control for biliary tract and HCC. Here's another study recently from Memorial Sloan Kettering. They also concluded that it seems to be GI histology seems to portend for worse local control. Most of their patients, however, in this series seem to have GI histology, so it's a little bit harder to tell or to how strongly to believe this. But I do believe, based on this figure here, that 0% local progression for non-GI histologies, but you can see that it gets to up to almost over 30% for patients with GI histology. So, and again, more data to suggest that perhaps something about the natural history or the inherent radiosensitivity of GI histologies need to be taken into account. And the reason why I want to ask that question is because I need to know maybe we should be tailoring the dose. Following Laura kind of mentioning the ALARA principle, certainly we want to use as low as reasonably achievable and as low as needed for different histologies. And so understanding which histologies need more dose, I think, will help us to be able to kind of follow that principle. So this was a study that I actually collaborated with Laura and Brian Cavanaugh. looking at, again, sort of our first registry, multi-institutional registry study that we did, we looked at colorectal metastases specifically. And we found that we were able to get about 100 lesions in about 60 or so patients. And you can see kind of the mixed bag here of different fractionation schedules that were used. Stanford at the time used a lot of 1 in 5 fractions. Colorado primarily used 3. And then Laura here, Princess Margaret, primarily used 6 fractions. That allowed us to do a little bit of dose analysis with this study. So for colorectal mets on univariate analysis, you can see that by local control, the factors that seem to correlate the best with local control were total dose as well as BED. And that was on the patient level. By lesion level, it was the size of the tumor, total dose, dose per fraction, and BED. And then for survival, max tumor dimension, as well as whether or not they had active non-liver disease, played an important role, and that was kind of echoed in the surgical series that I showed earlier. So plotting by just total dose, you can see that if you could get above 42 gray, you actually had a pretty good 1-year local control. But I think what was somewhat disturbing was the fact that if you have less than 42 gray, your local control actually falls less than 50%. This probably has a lot to do with the fact that tumors that tended to get lower doses also were much bigger. But I think it does just tell us that dose seems to be important. If you just look at by standard BED, you can also see a similar difference in local control. And then finally for survival, you can see that whether or not you had extrahepatic disease, that made a difference in terms of survival. On multivariate analysis, we looked at each of these dose metrics separately, total dose, BED, and dose per fraction. And those were the only metrics that correlated with local control. Interestingly, though, on survival, active non-liver disease also played a role. But what we found that was somewhat intriguing was the fact that, although not significant, it was near significant, whether or not patients had an early or late local failure. So if they were controlled beyond 12 months, they had a near significant improvement in overall survival. So we interpreted this to say that this may show that perhaps local therapy can have an impact on survival. We then did a dose response analysis where we converted doses to standard BED or looking at linear quadratic single fraction. And we found that using an endpoint of 90% 1-year local control, you needed a BED dose of 117 gray, or single fraction equivalent of 33 gray. And that translates out to 16 gray times 3, which is sort of the dose that I now have been using to try to make sure if I see a patient with colorectal liver metastases, I will try to attempt to get at least 48 gray in 3 fractions in order to optimize the local control. And that's what's, the caveats, of course, are that we're using linear quadratic model. We may be outside the range, alpha beta of 10. So, but at least it was sort of kind of one of the first studies to really show what was the dose perhaps needed for this particular histology. Brian then, with his group, he actually sort of did a similar analysis looking at 2 other histologies, renal cell and melanoma. And you can see kind of the wide range of fractionations that he used. With this, though, these are 2 histologies that we've traditionally thought were radio-resistant. But with that, encouragingly, they found an 18-month local control of near 90%, 88%. Significant factors on univariate analysis were fraction number, fraction size, and total BED. You can also see here that if you had extensive disease, your survival was worse than if you had true oligometastatic disease. But they did a very similar analysis to us, and they found that single fraction equivalent dose of 44.3 gray was needed for a 90% local control. That translates to 48 gray in 3 fractions, and a BED of 126 gray needed for 90% 1-year local control. Translates to 49 gray in 3 fractions. So the numbers were actually quite consistent with what we found, which in some ways is comforting, but in some ways a little bit disturbing because we always think of colorectal mets as should be radiosensitive, but it seems to be that they are about as radioresistant as melanoma and renal cell. And actually what he did was he took our data and then plotted that on this sort of sensitivity curve here, looking at colorectal in blue, in this kind of red-brown line. Here is the renal cell melanoma group. And then what he also did was he took the non-small cell lung cancer data and he plotted it here, which, the outcomes when lung SBRT was first reported for early stage lung cancer, the outcomes looked excellent. They were 90% plus. So we thought that was actually very encouraging. But you can see that based on the data, there's something more inherently radiosensitive about non-small cell lung cancer, whereas colorectal, although the curve seems to rise a little bit sooner, but if you're trying to optimize local control and get it above 90%, it appears to be at a similar level as renal cell and melanoma. So, I just put these data here. It's obviously, there's a lot more to understand, and some of this you could there's a lot of flaws in these studies. But I think that really this is kind of the direction that I'd like to see us go more, to really understand how best to optimize treatment. And for renal cell, I think that's also a growing field, and there is data for SBRT for renal cell, which not necessarily just in the liver, but anywhere else. And you can see that local controls appear to be quite good, near 100%, 80%, 90%. And so I think that this is also an area that can be grown. So I think more histology-specific studies are going to be important for us in order to move this field forward. I would be a little bit remiss not to, being here at Princess Margaret, not to mention Laura's phase 1 study, at least, just to show that there are different approaches. It's not necessarily always just trying to get the maximum dose, but if you want to follow the ALAR principle, they basically tailored the dose that they chose based on the effective volume and the predicted risk of radiation-induced liver disease. And so they basically did dose escalation studies within each of these effective volume bins to get the dose. And the median dose that they wound up using was 41.4 gray and 6 fractions. But even with perhaps up to a 20% predicted risk of toxicity, they really found no dose-limiting toxicities in this group, which is comforting. And I think it does sort of give me the sense that we probably are being overly cautious with metastases for patients who have really no underlying chronic liver disease. There probably is room to go up, but I think most of us are really just kind of taking baby steps and assuming toxicity is the worst before trying to get too cavalier, I would say, with the dose. But you can see, with the Italian group, 25 gray times 3, and they were still able to do that. They were still able to do that without really any noticeably high rates of toxicity. So how does SBRT compare to these other ablative therapies? Of course, we would love to have the prospective randomized trial to look at this, and there are some that are coming, particularly in the lung cancer world. The only data that I'm aware of right now with liver that compares SBRT with RFA, because RFA is really the major player, is a study that was done at the University of Michigan. This was presented at GI ASCO a few years ago. Actually, the first author is actually currently one of our residents here at Stanford. But they compared their series retrospectively of 127 patients who had treated with RFA, compared with 62 patients with 106 lesions treated with SBRT. And here they found that there was a difference in terms of which patients were treated with RFA versus SBRT. Most patients in the RFA group had hepatocellular carcinoma, colorectal primaries as well as a difference, number of active tumors, and whether or not they received prior therapy. And so they found that the 1-year and 2-year freedom from local progression rates were very similar, 86 and 83% for RFA, 93 and 84% for SBRT. So in terms of the univariate analysis for local progression, interestingly, they found that, as we mentioned before, tumor size makes a difference, particularly whether or not you were less than or more than 3 centimeters in size. For RFA, there was a significant difference in local progression based on tumor size. Whereas you see with the SBRT group, size did not seem to correlate with outcome. And then when they look at modality stratified by size, you can see that in the solid line, these are tumors that are more than 3 centimeters. SBRT actually was significantly better than RFA. So you could spin this data to perhaps justify SBRT for larger tumors. Whereas for tumors that are less than 3 centimeters, there was no difference. Looking at specific histologies, colorectal metastases, although these curves kind of look separate, but this was not significantly different in terms of 2-year freedom from local progression, 95% versus 86% for RFA and SBRT. And if you look specifically at HCC, SBRT actually did a little bit better, a 2-year freedom from local progression of 94% compared to 83% with RFA. So future directions, where do I think the field is headed? Where, and I guess this section is where I get a little bit soapboxy as far as what I think is lacking for us to really say that we're ready for prime time. I think cost effectiveness. I think in the current healthcare environment, especially in the U.S., this question is going to become increasingly important. And with any modality, I think that not just outcome, not just toxicity, not just those things, but also understanding, how does the cost play into this? I'm not aware of any cost effectiveness studies for liver SBRT yet, but I pulled up some that have been done for non-small cell lung cancer, as well as one that we did at Stanford for pancreas cancer. But most of these studies, they compare SBRT versus surgery. The first two are SBRT versus surgery. They conclude that SBRT is less costly and maybe more cost-effective. In fact, in this study, they said it was actually more cost-effective for those that were marginally operable, but lobectomy was more cost-effective if you're operable. And in this study, surgery was thought to be actually more cost-effective because you get better survival. But if we can improve survival, improve outcome with SBRT, then it may actually become a more cost-effective modality. This third study actually is from Canada. I think Andrew Hope was the senior author on this, but they compared SBRT versus conventionally fracture radiotherapy. The only caveat to this one, of course, is that they use the Canadian cost numbers, and so this probably doesn't quite apply to what happens in the US. But they concluded that SBRT is more effective and more cost-effective, I should say, than conventional fractionated radiotherapy. And then I'll just say in the last study here, this is Jim Murphy, when he was a resident at Stanford, looked at specifically at different treatment modalities for locally advanced pancreas cancer chemotherapy versus conventional fractionation with non-IMRT versus IMRT versus SBRT. And they concluded that that standard $50,000 per life year gain, that's sort of the metric that's out there. But they concluded that with that, IMRT is definitely not cost effective. SBRT is potentially cost effective, but both of them still exceeded that $50,000 per quality adjusted life year metric. But I only put this up here just to show that I think really this is the direction we need to go, particularly with liver, because we're not just comparing SBRT with surgery. We're comparing it to RFA. We're comparing it to microwave or radioembolization. Radioembolization is a very expensive treatment too. So I think that really this is going to be an important direction that our field really needs to go in order to really establish SBRT as hopefully a preferred treatment method. Quality of life. I'm not going to say too much about this because actually there's a talk I think later today. I think also from here on studies that were done looking at quality of life. But I'll just say that I think this is also another extremely important and probably kind of neglected area that we probably should be focusing on too. Of those modalities that I mentioned, of those, SBRT is the only non-invasive one, correct? So because of that, I think that there are some implications with quality of life that we need to probably, that's really kind of our main draw for patients, that we are non-invasive. And I think that doing more quality of life studies in order to show that and to show that hopefully that makes a difference in patients' lives is another important aspect that needs to be highlighted. I put this study here. This is a recent study in the JCO looking at patient-reported outcomes after resection, hepatic resection for colorectal metastases. This is important, I think, because this is, I think, what we could use this study as a baseline. They use the EORTC, a very well-known instrument, the QLQ-C30 survey, the instrument. And I think this study really should serve as a baseline for any future studies that we do with liver. I won't get too much into the details of it, but primarily they show that probably about 3 months or 3 to 6 months after surgery, you can see that quality of life scores do. This is the global quality of life. This is role function. You can see that they both dip down around 3 months, but then seem to recover. Fatigue and activity and vigor seem to get worse again within those first 3 months, but then they do improve. The one thing they saw that did not improve was this is sexual function. You can see that it continues to actually get somewhat worse over the first year after surgery. So their conclusions from this was that most functional aspects of health do decrease after surgery. I think that's something that SBRT does not cause. They reported that 30% of patients reported severe activity and vigor problems. The functional scales do seem to get better and start to return to baseline at 6 months. Post-op symptoms seem to improve by 1 year out. However, 32% of patients reported severe sexual dysfunction, and about 12% had reported abdominal pain. So these are the numbers. This is kind of the table's been set now, and this is what we should be comparing ourselves to. So, to answer the question of is SBRT ready for prime time? Well, we have to really ask ourselves about what are the potential benefits. Survival, that's always kind of been used as the classic outcome measure, but I'm not necessarily sure. I put question marks for all of these because I think really they haven't necessarily been proven, but I think they are areas that all need to be researched. Yes, it would be great if SBRT does improve survival, and that would be sort of the gold standard, but is it the only standard that we should be looking at? As I mentioned, quality of life is very important. Can SBRT relieve pain? Can it keep pain away better than other modalities, or 30 and 10 or something like that? Is it better at preventing symptoms, preventing obstruction, or preventing pain? Does it have reduced cost to other therapies? I think if the answer is yes, and you can still get a very similar outcome, that would obviously be preferred method. And something that I see a lot more in my practice, which I think really needs to be drawn more attention, I think this is a very worthy endpoint. With improvements in systemic therapy, some cancers or some patients with certain cancers, they almost be put into more of a chronic condition where every year or so, perhaps an oligometastasis decides to progress and it needs to have some sort of local therapy brought in. But in the meantime, they just basically stay on chemotherapy indefinitely. And that causes, of course, decreased quality of life, not to mention cost. And so oftentimes we're asked to give SBRT to give them a chemo holiday. And it's hard to quantify, well, what's that chemo holiday worth to that patient? It could be worth a lot, particularly if they're very active and they have other things they want to do, or if it has a major burden on their quality of life. I mean, I think that is an endpoint that needs to be studied more. And so avoiding the toxicity of therapies, not to mention the cost, is another very important metric that we probably should be doing, we should be examining in our studies. So my conclusions are, local control appears very favorable compared to other liver-directed therapies, equal or in some cases maybe better. We do need, of course, better understanding of which patients benefit. We need to select the right patients. I think that's true of any local therapy. We need to better understand outcome based on histology, which I think really sort of should be the next level of outcome studies that we see. I don't think we need any more. I treated 50 patients with mixed bag of histologies, and here's the outcome. I don't think we need any more of those studies. We need a better understanding of liver tolerance to optimize the dose fractionation. I think that right now we probably are under, and we could definitely have room to go up. And we need a better understanding of the impact on survival of SBRT and how to integrate that with other systemic treatments and even other local therapies. So I guess I should answer the question, is SBRT ready for prime time? I'd certainly think so. I would say yes, all capital letters with an exclamation point there. But if I were to have a wish list of what I'd like to see done, which I'm going to try to do myself, but also for those of us who now become active clinicians and investigators with SBRT, this is what I think really we need to do. We need to have head-to-head comparisons in prospective randomized trials of SBRT versus RFA or surgery or whatever other modality you want to compare it to. And you want to look not just at survival, not just local control, but I think you want to look at quality of life. So all of these studies need to have a quality of life survey component to it. Cost effectiveness, I mentioned, how does SBRT compare to that? Because, especially when, our decision or our ability to deliver treatment may be more dependent on, healthcare reform and healthcare policy, that may actually be extremely important, and we could get ahead of the curve if we really start doing more of these studies. I think we need large registry, histology-specific SBRT outcomes investigations to be able to understand which histologies benefit from what. We need nomograms to predict which patients do best, and we need really dose-finding trials for each of these specific histologies. These are my acknowledgments of all collaborators, co-investigators, colleagues, and with that is the end of my talk, and I'm happy to take questions. Thank you.